All right, we're jumping right into it, right? All right. Hi, everybody. Thanks for sticking around for this last one. We really appreciate it. I'm going to talk to you about I have some panelists here who are going to talk to you about the least controversial thing that we're going to discuss today, which is vaccines. As you know, there's been nothing about them in the news because they're all doing fine. I've also lost my filter and any sense of professionalism because,
Don't forget.
yeah, we are streaming. Okay, I'll behave. Thank you seriously for coming and for hearing this. We have three fantastic panelists here, and I'm just going to jump right into it. We're going to do something a little bit non-traditional with two of the panelists. Sophia Newcomer and Sarah Brewer are going to speak first, and then we're going to open it up to some questions, and then Noel Brewer is going to speak. So we're doing that because Noel's going to address some of the things that have happened with ACIP, and I don't want the discussion about ACIP to sort of suck all the air out of the room since that's a big issue. So that way we can hear about some of the rural trends in vaccines from Sophie and from Sarah, and then move on to discussing ACIP and how that is affecting rural people as well as the nation at large. So I'm just going to pass it right on to Sophie. Sophie is an associate professor of epidemiology at the University of Montana. Oh, I need to play from start. There we go.
All right, thanks everyone for sticking around for this, and also for Tara for organizing this session. So I'm going to start off the presentation by sharing some data on rural vaccination, and then talking a little bit about some trends that I see affecting vaccination, as a vaccine researcher who's embedded in a primarily rural state of Montana. So the reason we're talking about vaccination as a unique issue to rural areas is because vaccination coverage is persistently lower in rural areas of the U.S. So this is from publicly available data that CDC collects. And on the left, basically what you're going to see in these graphs is the blue line, which is always the lowest line, is what we see in rural areas. And then the red and the green lines are urban and suburban areas. But essentially what we see that the combined 7 vaccine series, which is a measure of whether kids are getting 7 routine vaccinations that have been recommended for a very long time, we see that that's lower in rural areas, has persistently been lower. If you look at the right, that's HPV vaccine series completion among adolescents. That's about 11 percentage points lower. So we see positive trends over time, but the rural areas just can't keep up. And of course, what we are interested in today with outbreaks occurring, including outbreaks in Montana, which we didn't have measles for over 30 years, and now we're dealing with cases in our state. But what we see is in rural areas, we have about 4 percentage points lower. And with a disease as infectious as measles, even a few percentage points really matter. And on the right, I've just shown where these data come from. It's CDC National Immunization Survey. So I know Sarah's going to talk about influences on vaccination uptake. And I know sometimes there's a lot of focus on individual attitudes, but really we think about spheres of influence on vaccination uptake. And one of the reasons that we see these persistently lower vaccination rates in rural areas is because the health systems and the policy environment look very different in rural areas of the country. So when we think about immunization services, the clinic and health systems that you have access to really matter. So when you're in an urban area, you're more likely to be getting care from a large integrated health system, private clinics. These clinics have the resources where they can, for example, utilize technology to help people know when their kids are due for vaccines. I'm a mom. And my kids, when they were little, we lived in Denver, Colorado. I was part of a large integrated health plan. I would get text. If I missed an appointment, I would get another text. I would get an email. I would get all these great reminders. Well, when we're talking in more rural areas, a lot of times if kids are going to a private clinic, it's a really small clinic, maybe a doctor, maybe a couple doctors and nurses, they just don't have that same type of technology infrastructure. Furthermore, when we think about resources, stocking vaccines can actually be quite expensive. So if you're a large health system, you're going to have that money, you're going to be able to stock vaccines. In rural areas, some doctors and some clinics aren't able to stock all vaccines. They just don't have that money to do the upfront purchasing. This is where public health clinics are super important to think about in a rural setting. Public health clinics are the backbone of rural immunization services delivery. These are state clinics, and a lot of times if doctors' offices can't stock clinics, they're going to be referring to the public health clinic in their county. So I just want to talk about two trends that I see right now are really influencing rural vaccination uptake. One is policy. So a lot of vaccination policy in the US is actually regulated at the state level, including requirements for school and childcare vaccines. And what we know, right now all states require vaccination for school attendance, and most states allow exemptions from this requirements for religious or personal reasons. However, how easy it is to get an exemption really varies across states. And so policy researchers have been able to study this, and what we know from that policy research is that when states make vaccine exemptions easier to get, the use of exemptions goes up. Sometimes because, especially in rural areas, it's easier just to sign an exemption than to try to figure out where to take your kid to get vaccinated. Vaccination rates go down, and then we tend to see vaccine-preventable disease outbreaks. So I want to just talk about what we're seeing in the policy arena, because what we've been seeing in the last few years is just a huge uptake in state legislatures in vaccination policy, most of it being anti-public health, anti-vaccine policy. So for example, in Montana, in the last legislative session, we had to deal with bills that were going to ban mRNA vaccines in the state, a bill that wanted to ban any vaccine that contained aluminum salt adjuvants, which is like half the vaccines that we give to kids. And so there's been this increase in legislative activity, but a promising trend that we're seeing is the response to the legislation that we're seeing in primarily rural states. So this is a map provided by a national group called American Families for Vaccines. Up until recently, they were called the SAFE Coalition. They recently rebranded. But they actually started in Maine because a group of parents in Maine were upset about some anti-vaccine legislation that they saw at their state legislature, and they decided to band together and work to promote pro-public health, pro-vaccine policy. And what they've become is now a national organization, and they work with states around the country to help grassroots groups of parents and advocates set up similar coalition. And if you look at this map, a lot of these groups are forming in primarily rural states because those are states that have conservative-leaning state legislatures, and that's where these bills are coming. So this is a positive movement. I'm on the steering committee for Montana Families for Vaccines. It's been great as a scientist and as a researcher to learn more about advocacy. And my kids are in that photo up there. I let them skip school for our day of advocacy. The second trend I wanted to talk about is this really just focusing on how nowadays we're allowing more vaccines to be given in pharmacies. And I wanted to point this out because this doesn't really seem like it would be a big deal. And maybe it is, maybe it isn't. I would say we just don't have a lot of evidence. So this is particularly important in rural areas because, like I talked about, sometimes doctors' offices can't always stock all vaccines. So it seems promising that pharmacies are coming onto the scene and offering more and more vaccines. This is also related to state policy because pharmacy scope of practice is also regulated at the state level. And then what we've seen is post-pandemic, more and more states have started to say the scope of practice can include kids and it can include more and more vaccines. However, there's concerns, especially among the pediatric community, that essentially what we're doing is we're decoupling vaccines from routine preventative care for kids. So the AAP, for example, has come out. They came out in 2020. Actually, during the pandemic, HHS kind of applied a federal rule that said any pharmacy can give any vaccine to someone over 2. That has sunsetted, so we're back to the state policy landscape. But AAP was very against this because they said, we don't want to decouple vaccines from preventative care. We want vaccines to be given by a provider who knows the kid, knows the family, and can provide everything else that they need for preventative care, along with immunizations. I wanted to point this out as a trend because, again, it affects rural areas, and really we have flu season around the corner. And this is another one of those graphs that shows what a disparity we have in rural vaccination in terms of flu vaccination for kids. And so more and more doctors' offices aren't stocking the flu vaccine because they say, hey, our pharmacist, our local pharmacy has it. Well, what we're dealing with now is a diffusion of responsibility issue. Well, then whose responsibility is it to promote flu vaccines in kids? And then I'm going to end on one point, which isn't really a trend, but I find myself as a vaccine researcher thinking about where we're going, and I think about where we've come. And just a point of interest here is that modern vaccinology in the US actually started with a Montanan. So this is a picture of Dr. Maurice Hilleman. He was born in Miles City, Montana. There are 2 stoplights in Miles City, Montana. Very rural, very agricultural. He developed the MMR, hepatitis B, pneumococcal, and other vaccines that are still in use today. He is the scientist that is credited with saving more lives than any other scientist. And so Montana Families for Vaccines, we do a lot of work in promoting his legacy in our state. And I just wanted to kind of plug something. If you're free tomorrow, this is August is Immunization Awareness Month. Next week is Dr. Hilleman's birthday. We have, if you sign up at Montana Families for Vaccine, you can watch this documentary about him. It's an hour long, and we're having a panel discussion. So just a point of interest that that infectious disease prevention started from rural Montana. Thanks, and I'll turn it over to Sarah.
One quick thing I wanted to add before we go over to Sarah is not only was Hilleman from Montana, the fact that he's from Montana is the only reason we got the measles vaccine, because we could only get the measles vaccine if we could grow the virus in eggs that were not affected by poultry leukemia, and the only person in the entire United States who had a flock of chickens that didn't have leukemia was in California and was not going to share them until Hilleman flew from Merck in New Jersey out to California, asked, was turned down, started to walk out the door, noticed his accent and asked where he was from, and they grew up 20 minutes away from each other in Montana, and because of the Good Old Boy Network, that's why we have the measles vaccine. Sarah.
Did you answer? Yeah, it's in the documentary.
I love that story.
Hi, I'm Sarah. Well, how do I swap things over here?
Sorry.
It's okay.
For you.
I just had that moment of like, ooh, this is.
No, I was too busy telling my story. Here we go. No, that's Noel's. So let me close out. Where did yours go? It's on the other side. Oh, maybe I didn't open it properly. There we go. Okay. Thank you.
Thank you. Hi, I'm Sarah Brewer. I'm an assistant professor of family medicine at the University of Colorado, and I work in our Adult and Child Center for Outcomes Research and Delivery Science, which is a big, long mouthful to say that we do a lot of work to focus on how we move evidence from kind of basic science to clinical science and then out into clinics and the community. So I am going to spend some time talking about what are some of those drivers for why rural vaccination rates are consistently lower than what we see in urban areas. And I'm going to do this through kind of a case study of some work we've done in Colorado, specifically focused on adolescent vaccination rates. So Sophia did not present as much on adolescent vaccination rates, but we see consistently that Tdap, meningococcal vaccine, and HPV vaccine have lower uptake and coverage rates in rural communities than we do in urban areas. And this has been kind of a persistent problem since the HPV vaccine in particular has been released, but even before that for the other vaccines. So some of the work we have been doing in Colorado is to figure out, one, what's driving that? Is it truly unique in rural areas? Are there drivers that are different or the same? And what can we do about that? So we've been working really hard with several rural partners across the state of Colorado to address that. One of the things I'll say about Colorado in particular, when you look at some of the maps we've seen throughout today, you see this kind of urban core down the middle of Colorado, and then you see these rural areas, and Colorado is unique because not only do we have counties that we consider rural, but we have almost half of the counties in Colorado are considered frontier, which means that they have even less population density than what we think of typical rural areas. And so I do think that there are some pieces of our Colorado context that are pretty unique to those frontier counties, in that the counties that are in that middle space of being rural are actually serving several surrounding counties that are frontier, who probably have no healthcare infrastructure of their own. Those people are actually traveling to those rural centers, and you'll see that in some of the kind of themes and data that we have seen in Colorado. So as I dive into these, main point up front here, our reasons for coverage that is lower in rural areas are several. They vary by that context, so we've been talking about that a lot today, that no rural is not a monolith. Every community has kind of unique factors that are driving this. And the factors that we see are often interconnected. In no case is there one driver of those lower vaccination rates. Instead, what we see is that there are several barriers that they interact with each other or exacerbate each other, and that while we might have this preconception that hesitancy is what drives lower vaccination rates, what we actually heard when we went out and talked to people and their physicians and heard stories is that that's only a small portion of what's contributing to under-vaccination. And it may contribute in many cases, but it's not the only thing that's driving why folks do not get all the vaccines that are recommended for them. So what does contribute to some of those lower rates? What we have found first in rural HPV and adolescent vaccination, and then seen this confirmed across several other vaccine sort of contexts, is that they really fall in three big buckets. So the first are these structural barriers. Those are the way our system is set up, and those are policy drivers. So availability of vaccines, availability specifically in primary care settings, costs, and technology for reminders. So Sophia brought up many of these already, and I'll provide some more detail on some of these. The second are logistical barriers, and we've been hearing about several of these that contribute to under-vaccination throughout today. Some of that's technology. Some of that is the travel time and transportation resources. Specifically, we heard a lot about time away from work and school, and that is intertwined with primary care availability and hours and things like that. And then that there are fewer resources like school delivery sites or pharmacies to deliver vaccines or mobile vaccination resources. And then the last bucket are these health beliefs and behaviors, and some of that is vaccine hesitancy, but a lot of that are how people use healthcare, how people interact with kind of primary and prevention in their communities. So I want to walk through each of these and just give people a little bit more of a sense of what some of these barriers look like. And because our data came from research, I can't play recordings of our interviews with folks with you, but I can read some of the quotes that we heard, which I think are really powerful for some of these. So I'll start with structural barriers, and what we see in rural communities are that primary care providers face a lot of barriers to stocking vaccines. So we have the Vaccine for Children's program, and what we often hear is that this should be kind of a silver bullet for ensuring that low-income families can vaccinate their kids. But what we heard from providers and from the families who see them was actually that the Vaccine for Children's program has a lot of administrative barriers in place that make it really difficult for primary care to stock in their clinics. And particularly for low-volume vaccines. So in our case, we heard that about adolescent vaccines. If you have a family doc who's only seeing maybe 5% of their panel are adolescents, they just don't see enough people of that age group coming through to warrant going through all of the administrative burdens to stock vaccines for children vaccines or any of those adolescent vaccines. in order to go through them fast enough to not waste those vaccines and spend all that money, right? So it's a key piece of how we kind of stock and provide for those kids who might be on Medicaid, but also for the population as a whole. And then what we heard was, okay, so those primary care providers then refer to the public health clinic. And that's wonderful, except that rural public health clinics often have less capacity. And over the last 5 years, we've also seen several rural public health clinics closing down their immunization clinics. It's a key resource in rural areas, and it's not always available. And so while that might sound like a great alternative, when you have a provider that refers to a clinic that then stops offering that service, you are now increasing the time and distance for those families to reach those vaccines or just removing that access entirely. The next thing we heard about was a lot about cost and insurance coverage, and this interacts with that first one around being able to stock it, right? It's costly for the providers, but also becomes costly for families. And in rural areas, part of that was that is that families in rural areas are more likely to be on either grandfathered insurance plans or on health co-ops. And so what we heard is that folks still have to pay a copay, an administration fee. And so I'll read a quote from one of the mothers we talked to. The people whose kids are on the child health insurance plan, a step above Medicaid, it's one more cost for them. They don't have it. It's going to cost $20 for each administration fee. Well, if they need 3 shots, that quickly adds up to $90, right? So while we say these are preventive care that are covered, if they are going to the public health department and need to pay that administration fee, or they are on one of these grandfathered plans, they are likely still paying a significant amount in order to get these preventive services. And then lastly, sort of like Sophia brought up, a lot of rural providers don't have the advanced EHR technology to be doing text message reminders or other reminder systems to make sure that families stay up to date. And then we heard from providers, and so you'll see here, we surveyed the rural providers from across the state of Colorado, and you'll see that our rural providers were far less likely to strongly agree with these statements about vaccination, but a couple of these are really important. Most of my patients have insurance that covers vaccination costs, right? 70% of providers in urban areas said that that was definitely true most of the time, while only 50% said that that was true in rural areas. And so we're seeing that cost piece come out again. The next bucket of things that we heard were around logistical barriers. And these are the families just being able to get where they need to be in order to get vaccinations. And so what we saw in rural communities was that it takes a lot more time. And some of that is distance. Some of that is travel can be more challenging. So we were talking to rural Colorado, right? And again, this is one of those, rural is not a monolith. In Colorado, we have a lot of mountain passes. And so we heard not just like, it's far, it takes me a while, but also travel can be treacherous. If I need to get to the public health department that's on the other side of a mountain pass in January, I'm gonna not do it. I'm gonna choose not to make that trip, and we might delay that vaccine, or we might just decide not to get it. And then there aren't often a lot of public transportation options, so families say, if it's not easy and convenient, after I've already been to my primary care provider and been referred to public health, I'm not gonna make it over that next hurdle. And then what we heard was that folks in rural areas were far more likely to report to us that they had less flexibility for missing school and work in order to make appointments in the middle of the day. So one of the things, I want to read a quote here as well. So this is from a mom of 2 in rural Colorado. Sometimes it's difficult because when it's a school-age kid, you're really limited to when you can get them in. Because I could take them out of school, but then that's another barrier. Picking them up, especially the 11-year-old that's in middle school, it's very difficult to get into the school, get her out, go to the doctor, then get her back, and try to do that in the period where there's only one class that she's missing. so that she doesn't have to miss several classes, right? And so parents are really thinking about, how do I fit this into a day, especially if I have to go, 2 towns over and this turns into a 2-hour thing, 2 or 3 hour thing instead of, popping across town. And then the last bucket of things that we hear are around health beliefs and behaviors. So in rural communities, we've talked about already today that healthcare utilization is often lower, and ED use is higher. ED is not going to provide preventive vaccines for most people. There are cases where EDs are doing this more often, but that's not the ideal space to be thinking about primary and preventive care, right? And then the other thing we've been hearing all day, right? Fewer healthcare resources are available in these rural areas. And so again, it just makes it less easy for families to engage in preventive care behaviors. Families also have lingering concerns about vaccines that are perceived as new or using new technologies. And I say new here as perception, right? HPV vaccine has been available for over 2 decades. Most people would not consider it new by today's standards, but we hear that perception from folks. This is a new thing, and that puts it kind of further down their priority list of what to get for their kids. And then the third thing we really heard in this space was this kind of cultural piece of rural communities around. In Colorado, we call it rugged individualism or rugged frontierism. But this idea that we can do it by ourselves, and that often translated for parents into my immune system can do this for itself, but also that taking preventive care like vaccines could be perceived as weakness. And so this did color people's decisions about how to engage with some of the other logistical and structural barriers in their communities. Again, thinking about kind of the beliefs and behaviors, when we surveyed providers, part of what we heard is that fewer rural providers thought that their patients perceived them as having a really good relationship. And part of that was actually that we heard parents say, it's really hard to get in with the same person. We have what they referred to as like provider churn. And this interacts with all of the workforce things we just talked about, in that folks would feel like they finally got set up with a provider for themselves or their kids, and they'd come back the next time and be like, oh, they finished their rural rotation, or they got their loans paid off. And so rural communities really felt like, I don't have that trusting relationship that helps me deal with my concerns about vaccines. And so again, I'll choose to just let that slide. So just circling back, the reasons that coverage is suboptimal are varied and interconnected. So one of the things we have been really focusing on is that mitigating any one of these doesn't necessarily make vaccination easy. It really needs to be multi-pronged approach and thinking about how we can address the ones that are most prominent and how we can address them in conjunction with each other. I'm just going to share a few things that we've been working on, and I know several others in the vaccine delivery space. There are some things we can do about this. One of the spaces where we are focusing a lot of our effort in Colorado is thinking about how we work with providers to improve communication and recommendations, especially in rural areas. So training around providing a strong recommendation and training around communication strategies that help providers build trust and move toward vaccination with individual patients. Access strategies, so things like mobile vaccination clinic, things like evening and weekend hours to allow families to get to vaccines when providers are available. Engaging community, so we've been doing a lot of work around COVID vaccine, HPV vaccine, and we just finished up a large project with our state health department using community engaged strategies to promote measles vaccination across Colorado and increase kindergarten up-to-date rates. And then lastly, thinking about policy options like updates to Medicaid and VFC coverage and rural access initiatives that help increase access overall. And I think I'll end on just a few notes. I think there are lots of pending impacts on vaccination, but rural health in general, with changes to Medicaid, with changes to VFC, which, for example, it is based on ACIP recommendations, which we'll hear more about in a little bit. But if those recommendations change in some of the ways we might anticipate, that would decrease access to some of the vaccines that really do protect kids. I think one of the things that I think is a really important thing to be sharing with the world is declines in kindergarten vaccination rates and how they interact with increasing exemptions. And then I think one of the stories we often don't tell that helps people get over some of these barriers cognitively and be willing to engage is talking about more the long-term benefits of vaccination, especially as we have more and more vaccines coming out to prevent cancer, right? It's not about immediate infection, but several vaccines that prevent long-term disease. All right.
I keep trying to not do that. Thank you very much, Sarah. And I'm going to add on some of those, some of the other story ideas you can do, especially for those of you who are covering a lot of rural areas, is investigate what are the policies in those counties, what kinds of rural vaccination clinics are or are not happening, talk to the providers, what are the providers doing, what do the providers need. There's so many rich opportunities for exploring all of those different barriers in your local areas, so I hope that you guys will do that. And in looking at those long-term effects of vaccination that are positive, one way to get at that is to cover the long-term negative sequelae effects of the vaccines. There was just a recent thing on how the COVID infections will have a deterioration in your blood vessels, and we're seeing more and more on that. So if we talk about and report on the fact that multiple COVID infections are, repeatedly deteriorating your blood vessels, but vaccination offsets that. We saw less damage with vaccinated people. That kind of story can also kind of help people understand what those long-term benefits are. We're going to go ahead and open it up to questions now for about maybe 10 minutes, 8 minutes-ish for Sarah and Sophia, and then we're going to move over to Noel's presentation. So does anyone have questions for our two rural experts here on vaccination?
Hi, thank you. This is great. My name is Karen. I'm a local freelancer. I forget which one of you it was that mentioned the Vaccines for Children program and how that actually is kind of paradoxically a barrier. And I just didn't get all the detail on that, and I just wondered if you could explain why in a little bit more detail. Thanks.
So I think I understood your question to be not quite understanding the Vaccine for Children's program and how it interacts in rural areas. Yeah, so the Vaccine for Children program essentially is supposed to provide free vaccines to families who can't afford them. And one of the things that we would anticipate, right, there are higher Medicaid coverage rates in rural areas, so we would expect Vaccines for Children to be providing more of the vaccines in those spaces. But what we heard in many of our almost every provider I've talked to in rural Colorado is that that program is administratively burdensome, and so they opt out of providing those vaccines to their patients. So instead of providing Vaccines for Children doses in their clinic, they refer their patients to public health or to another provider, usually public health because there aren't a lot of providers in rural Colorado who deliver the Vaccines for Children doses, which are provided through CDC. So it's not like you can just buy them and get reimbursed. They actually come from a different source. And so what that means is that that sort of starts a chain reaction of if I can't get it at my pediatrician's office because it's too expensive and burdensome for them, then I have to go somewhere else, which adds trips, which adds time and distance, right? So it starts this kind of cascade of issues for families rather than getting it at your primary care visit when you would hope that most kids are getting them. Go ahead.
I'll add a couple things about VFC. You have to keep separate freezers. So you have to keep a stock of each vaccine in duplicate. And then there's the sort of auditing that happens periodically. You have to deal with that. In addition, there's the copay that folks mentioned about with Obama, with the Affordable Care Act. There's first dollar coverage if you're privately insured. There's no pay. There's no paying when there's vaccines. But for Medicaid, anyways, for the VFC program, there is a fee. It's a set fee. It's capped and it varies. It used to be around $20. The reality is, and if you can't afford it, you're not required to pay for it. The reality, though, is that many providers do still charge and even charge quite a bit more. So that actual cap and that number is a small fiction.
I know there's another question, so I'll ask this real quick. Are these problems, are people at VFC aware? I think I realize it's administered by CMS, right? So I think. Are they, or maybe it's administered by CDC. I know it's funded by CMS. But anyways, are the people in charge of it aware of these problems and trying to fix them? Or is this because of all the edicts from HHS, is this kind of a moot point? Is this program on its way to being eliminated anyway?
My perception from working with clinics in Colorado, at least, I think there's some knowledge of this at the CDC level. There's a lot of knowledge of this at the state level. So there are levels of management here. CDC buys the doses. States usually manage the programs. And Colorado does a lot to support clinics as much as they can, but there's not a lot in the program to make that possible, right? So the state's really kind of subsidizing that work. And doing the best that it can. And they've made progress since we collected this data. I think we've gotten several more clinics in rural areas onboarded with VFC. But it also is just a function of keeping separate stock and separate fridges and having separate billing procedures for that and documentation. And then there's a strong encouragement from CDC to also participate in QI programs that go with that, right? So those are all good things for managing that program, but they aren't easy given all of the other things that rural providers are trying to do, and when they're in family medicine clinics, so the volume still, again, is lower than you might expect in a pediatrician's office.
We're going to go to your question in just a minute, but I want to add, if you would like more information on that and what your state's doing, I highly recommend contacting the Association of Immunization Managers. Every single state has an immunization manager at the state health department, and that's who, it's one or two people, and they are the ones who have to manage that. The executive director of the National Association of Immunization Managers is Michelle Fiscus, and those of you who follow the immunization space will know that she is the person who was in Tennessee who got fired for doing her job, which was recommending vaccines, and she is a tremendously helpful source, so she can help you understand some of these structural issues in multiple states and at the individual state level, so that's a really good resource.
This is kind of a provocative question, but why don't we send vaccines directly to people?
Like to their houses?
Like in the mail.
To their houses?
Yeah.
Well, because they can't administer them to themselves. I mean, you might have seen in the news recently, now there's like a nasal flu vaccine that can be given at home. There's like certainly innovations and vaccine delivery methods, delivery in terms of like how we're actually giving the immunization. But I think you bring up a good point, which is like, how can we bring immunizations closer to people? How can we make it more accessible? But doing it in your own home, we've started to open that door, but there's still more science to be done.
There's also a problem with the cold chain. You have to maintain a temperature for most vaccines over a period of time, and that goes away in the mail. Mm-hmm. It's one of the big problems globally when you try to get vaccines to remote areas, even by using drones and all the rest, is that you maintaining the cold chain is one of the big interrupters. And so, for example, with HPV vaccine, they're trying to develop a vaccine that does not require a cold chain.
I have a question on the recent ACIP vote and HHS policy on thimerosal in flu vaccines. When the change or the vote first happened, we heard from a lot of...
Can we do that later? I promise you we'll do a lot on ACIP. But
Okay,
yeah,
great.
We'll hold that.
Yeah, sure.
Yeah. Thank you. It's great.
If there's no
Yes.
other questions, we'll actually move on to Noel now.
Right.
Okay. So most of you, hopefully all of you know that in the summertime, HHS Secretary Kennedy fired basically the entire ACIP. Yeah, here's one of our fired people. That's Noel.
Yeah, what do I do here?
Catherine, no, Catherine's not here.
Some states are moving toward like letting people next to
Does it?
VFC and
Oh, I don't know Catherine's password to.
but they don't have to.
Okay, well.
Well, let's do the thimerosal question while we're here. Questions are always more interested in me talking, so let's go.
I was going to say, so after the vote, we heard from a lot of experts that like this really isn't a big deal because so much of our supply is already thimerosal free. But I'm wondering, when you're talking about so many of the barriers and storage being one of them, I'm curious, are those multi-dose vials, were those used in rural communities or not so much? And if so, how can we see this impact the upcoming influenza season, or will it not?
So the background is that ACIP, after they fired all of us and brought on some new people, did a vote on seasonal influenza vaccines that removed thimerosal from the remaining things that had thimerosal in them. It's a preservative, it's very safe, the data are unequivocal that it is a non-issue. Thimerosal was removed some 20 years before, mostly to quell public outcry, but not for any valid scientific reason. So, and the data haven't changed, the data still show that it's really safe. In terms of the vaccines that it affected, it was, as you mentioned, these multi-dose vials, and then also vaccines for pregnant women. And so my understanding is that the multi-dose vials may sometimes be used in rural areas, but I don't actually have a straight answer to your question. Do others here have a better
my
answer?
understanding is it was less than 5% of flu vaccines. 1 to 2%. Yeah, like a very small percentage. And I don't think there's evidence that it's like used more in rural areas or not. I think maybe the bigger issue with the upcoming flu season is, and I brought this up earlier, is who is stocking flu vaccines and how that is really changing the landscape of flu vaccination.
Yeah, and I mean, when they made the change to the recommendation, which trickles out in various ways, including VFC, the Vaccines for Children program, they stock only vaccines that are recommended by ACIP. So when that got removed, then all of a sudden the VFC coverage went away. So that's about half of the vaccines provided to children in the United States. So that's consequential. It's unclear what, as you were saying, what the exact consequence of that is in terms of rural versus urban areas.
Knowles is you see it? It's. Yeah.
I want to talk to you about HPV and public health clinic.
So I'm going to talk about vaccine policy in the United States, and I'm going to apologize in advance. I did bring slides like my colleagues. I think scientists think better with slides. It doesn't mean that you're going to get a better talk with them, but at least I won't forget as much stuff. All right, I have various roles. I am a member of the U.S. National Verification Committee for the Elimination of Measles, Rubella, and Congenital Rubella Syndrome. We meet tomorrow to see whether the U.S. still has maintained their elimination status. That'll be interesting. I have other roles in WHO and CDC over time. Then I have various past funding from federal sources, foundations, as well as industry. So I wanted to lay out in fairly specific detail what ACIP does, the Advisory Committee on Immunization Practices that was so much in the news. And then I'm going to go through a bit of the what happened. I think a lot of us have seen specific sort of snapshots, and as journalists I think you're more cued in than most, but I thought it would be helpful to just get it all in one place. So ACIP has 5 standing work groups, and these work groups exist at the instruction of the secretary of the organization, of the ACIP secretary. So there are at least 2 ACIP voting members, members from the main group who must be there. It includes liaison members like from the American Academy of Pediatrics, the Family Physician Association, all the rest. And then a dozen, 2 dozen, 3 dozen CDC experts. So these groups are large, 40, 70 people who meet on a monthly basis, and then maybe they'll meet a little more often before the big meeting that happens publicly. So yeah, maybe meeting monthly a little more often. They develop a policy question. What is the policy question? And this vaccine for what age and so on. They review the evidence that's available, often evidence including data that are not available to the public because it's data collected by the CDC or it's data collected by industry and they're able to, CDC will invite them to share what they know. They developed this thing called an evidence to research framework that allows us to look at effectiveness and safety, but also equity, also access, acceptability, several other things as well. The data, depending on the topic, will also undergo grade analysis on the certainty of what we know. And then the work group reaches consensus. They come to some agreement about which direction to go, and if they don't come to agreement, they play with the questions a little bit to find the places where they do agree. And if there's still disagreement, they bring that to the larger group. So this full committee is a federal advisory panel. It has up to 19 members. It's appointed by the DHH secretary. That stuff is somewhat familiar to us. As a federal advisory panel, it has some fancy rules about it. It meets 3 times a year for 2 or 3 days, typically in person, although it did it remotely in April. It also has done it remotely during COVID. They review work group presentations, including that ETR that I told you about. That includes also the grade analysis. And then they vote on these policy questions. All right, so all of that is how it used to be. On May 20th, the FDA published an article in the New England Journal, and that article jumped fully in the middle of ACIP's business, and it set new policies for COVID-19 recommendations. They said that it will only be ages 65 or older or high-risk individuals. It ended vaccine recommendations for healthy children and adults and pregnant women. That's a big deal. There are some really important high-risk populations there, in particular among young children. COVID most affects the oldest and the youngest. The highest risk group is 75 and above, but then 65 to 74 is the next group, tied with 0 to 6 months old in terms of hospitalizations. Those are really high risk groups. We can't vaccinate 0 to 6 month olds because there's no data. So instead, you vaccinate the moms. There's more to it than that 6 month to 23 month olds are also incredibly high risk. All right, so on June 9th, the Secretary of Health and Human Services fired all 17 ACIP voting members. There were 17 at the time, 2 had cycled off and more were coming on. They removed the Secretariat and then they ended the meeting of the work groups. I will say, as one of the people fired, it's the first time I've ever been fired in the pages of a national paper. It's a really odd experience to have a journalist email you and say, hey, have you seen this? I think this is about you. Thank you to CNN. All right. So our committee got together and we wrote an article. We got together that night, and as we were meeting, we were getting our emails. So at 4 p.m. is when the article went live in the journal, and then we started getting our emails, and I got mine at 5:48 that night. We met until about 7, I think, that night, and then we agreed to write something. On Tuesday, we wrote it. On Wednesday, we sent it to the journal. On Thursday, they accepted. On Friday, we edited it. On Monday, it came out. And that's our sort of narrative of what we think is going on. Now, on June 12th, the Secretary appointed 8 new members. One of them dropped out overnight, probably because he didn't want to declare his conflicts of interest. It's unclear, but that seems to be the story. So this is a small committee, and it's lacking certain experience. It does not have pediatric primary care experience, and that's a pretty huge gap. Not only knowing what to do, knowing the barriers that are involved in providing the care. And it doesn't have to be pediatricians, it can be family physicians, but you have to be treating kids. And the guy who's on there has medical expertise, is an ER doc. There's vaccinology experience missing, clinical trials experience, cost effectiveness experience missing. And this nice little article in Science summarizes the number of articles published by various members. I don't put it up there to make myself feel good. I'm at the top there. But it's more to show that there really is a stark difference between the number of articles written by the former members, who were in light blue. The average was something like 49. And then the new members, many of whom have not published anything at all, I think the average was 11. There's just different groups entirely. So June 25th to 26th is when the ACIP meeting happened with this new group. The American Academy of Pediatrics declined to attend. One of the ACIP members, the new ones, characterized it as a boycott and sort of stamped his feet about it. And then others of us sort of thought it was a bit of a heroic move, and we really thought it was great. I don't know. Can we settle on conscious uncoupling? Is that a thing for this? All right, so there was evidence on thimerosal with no ETR and no grade. Big break with the reliance on evidence, kind of a huge moment. The vote to remove thimerosal from vaccines was a big deal. July 31st, liaison members were barred from work groups. Also a huge thing. So what that means then is that these work groups are now, it used to be that you'd have voting members, you'd have a few experts, you'd have the liaison members, and then a whole bunch of CDC folks. CDC folks could not vote. They could express opinions and so on, but they couldn't vote. So you've taken away a huge amount of the voting capital there that allows them now to muscle through all sorts of things that would never be acceptable to the medical groups. So with all of these changes, the medical societies have fundamentally walked away from ACIP. They just don't trust it anymore, and it's creating chaos for primary care. We wrote another paper in the New England Journal where we talk about a path forward, and we identify a couple options. And I'm going to go through those in some detail here, briefly, but in some detail. So one option that we identified was that medical organizations would create their own vaccination schedules. And indeed, that's where we are already. That's what's happening. And if you know the Vaccine Integrity Project, they have been helping to coordinate and have different groups meet. So the American Academy of Pediatrics, AAP, is handling the children's schedule as they've done since, I think, 1935. They have definitely uncoupled from ACIP in that regard. Then there's the family physicians and the American College of Physicians. They're handling the adult schedule. IDSA is handling immunocompromised. And then ACOG and SMFM are handling pregnant people and a schedule for them.
SMFM is the Society for Maternal Fetal Medicine.
Thank you. Letters, yeah. Public health, that's one of our weak spots, is we love letters. All right, so there are real limitations to this. This is not a good solution. It's a better solution for public health than relying on ACIP, but it's not a fundamentally good thing. It doesn't compel coverage for vaccines by private insurers, by VFC, or by other public programs. And there's various other groups like you can think of, like the VA, what will they do, and so on. Private insurers have said they'll go ahead. They're good with this. It's unclear how long that will last, which vaccines they'll choose to cover. The schedules may disagree. Already they're using somewhat different approaches. I mean, it's good news that AAFP is doing this deep dive that's very evidence-based. That's the family physicians. They've been, and there was just some things released recently on that. Fantastic. And ACP will follow, probably just amplify what AAFP says. It's unclear what's happening with the other groups. But even when you go from adults to children to immunocompromised to pregnant, how will those line up, with one another? It's unclear whether there'll be gaps, whether there'll be different language, different approaches. And the idea of having a really clean, tidy, similar format and all that is a bit out the window right now. There's limited capacity. These organizations are doing their best, but they don't have the full court press that ACIP used to have. There are delayed or non-existent data that they will simply never see or that they will see a year or 2 or 3 later. And then the loss of CDC staff expertise is extraordinarily difficult. They were the mainstay of what made all of ACIP's work strong. So a second possibility is an auditor. So a group that looks at the ACIP presentations and the meetings and says, well, this is good, that's bad, there's these issues going on. There are various ad hoc efforts. We former ACIP members, as well as 5 who are about to come on, so the 22 of us, have started to take on a little bit of that role. But we don't have, the limitations include, whatever we say doesn't connect to insurance coverage, either form, the public or the private. It's a bit ad hoc with no clear audience. We just say stuff and hopefully people will listen. And then the volunteer work, it's volunteer work without any kind of support. Now the final one was a fantasy, a parallel ACIP. Some people call it a shadow ACIP. It sounds a little spooky, but whatever it is, it's not going to happen. It's simply not going to happen. There's no current actions on that right now. There are a lot of limitations. The most important one is on the bottom here. The estimated costs were about $2 to $3 million a year to run ACIP, 10 full-time staff, and then maybe 100, 200 CDC folks who are truly world experts, all brought in for a little bit of their time. So the future outlook with patients is certainly following vaccine confidence. There's no question that that's going to be one of the consequences when the public sort of knows what's going on, but the amplification from DHHS and even from ACIP members will be taking a toll. So we can see drops in uptake, and probably in some areas, and I would certainly think in rural areas, it will exacerbate all the issues that are going on in rural areas. Providers, it's created chaos, complete chaos. What should they follow? What's coming soon is they'll have this guessing game of saying, you got to get this vaccine. Now let's see what your insurance is going to do. Pharmacists are really good at sorting out, adjudicating claims in real time, but providers, primary care providers, generally not so much. So ACIP, we can see, will be covering fewer vaccines for narrower age groups. Even though insurers show initial support, we don't know where that's going. And then one of the things that I'm concerned about is the possible loss of measles elimination in the United States, that we are cruising right toward that. I'm not speaking as a member of the committee. That I'm one of the 7 people who establishes whether we keep it or not, based on the data that we see from CDC. So the data I've seen so far look promising. There's probably good news. We haven't gone for that full year with an uninterrupted strain of transmission, but we have all the right ingredients for this. We have done everything we can to make measles endemic again. We have, I just looked right now, we have I think 1,375 cases in the United States, according to one count, 3 deaths, and typically for every death you have about 1,000 cases. So something doesn't line up. It might be that these cases are happening in places where there's less strong care. Rural areas have less capacity for this kind of thing. That could be it. Or it could be that there's a dramatic underreporting of cases. Whatever's going on, we definitely have a problem in the United States with measles, and I would think that would be playing out in rural areas as well. So in terms of story ideas, I think that one particular one is to identify, for you, if you're interested, to learn about the hot spots where vaccination rates are low. Across the United States, we're 92, 93% for measles vaccination. Kids get it at age 1 and they get it again at age 4, their booster dose. You look at exemption rates for kindergarten is one way to look. Another is there's I think a Kowalski paper that has identified areas at particular risk for a few different reasons. These cluster together. That people who don't vaccinate are clustered together. So this 92% is not 92% flat. Some areas are going to be at 70%. Others are going to be at 98%. And it's those lower coverage areas that are the issue, especially among communities where there's a lot of closeness. So some of the outbreaks we've had in the past have been among religious communities where they spend a lot of time physically in each other's presence, and that can cause the reproductive rate to change and much more spread. So I'll pause there. And despite all the gloom and doom, despite all that, providers are still talking to families about vaccines. They're still being provided. Rates are still relatively high in the United States. And even as we have our vaccine policy apparatus taken apart systematically, and people from the front of the room saying things that will cause drops in vaccination, I still think that we have some hope of making it through the next few years with children mostly healthy. And that's just what we're going to have to hope for. Thank you.
I'm not touching that thing. That's how you know he works in public health, because he's still hopeful. I also want to mention on the clusters, if you decide that you want to do any kind of research into clusters in your area, and you want supporting research to show, hey, this is what happens when there's clusters. I have done a lot of reporting on that, and I have literally about a dozen studies showing clusters correlate with pertussis, with measles, with all these different things. Feel free to email me. I will send you all those citations happily. I will send you the full studies, because I'm happy to share that information. Questions?
Do you want to go first? I feel like
Thanks.
I'm at this, Michael.
No, I'm curious, in such a short amount of time, we've seen policy change around COVID, and it's likely going to get narrowed even more when the new vaccine comes out, and flu. And I'm curious if you guys have any suspicions or concerns about what vaccine might be next, where we might see policy changes going forward?
Yeah, HPV vaccine. It's coming. One of the foremost skeptics of the vaccine is currently on ACIP. It's coming up for some sort of discussion in September, in their September meeting. So I don't see good things happening there. That's a vaccine that could prevent 37,000 cases of HPV cancers a year. There's no reason to get or die from cervical cancer. Between vaccination and screening, we can all but eliminate it in the United States. Reducing access to that vaccine would be a really large harm. Do others have a?
I echo all of that.
I would agree with that. I think the other one to keep an eye on is like the recommendation for Hep B vaccination at birth. That has come under scrutiny in kind of anti-vaccine policy circles. Super important, though, for preventing actually chronic liver cancer later in life if you were to contract Hep B during birth. So another one to keep an eye on.
It's worth noting that both of those vaccines are literally the only two vaccines we have that prevent cancer.
Yeah.
That's 8 different kinds of cancer that are prevented by the combination of those two vaccines. So that's something I really emphasize when I talk about. We have vaccines that prevent cancer.
I wonder if any of you could talk about what's happening with FDA labeling on vaccines right now and how that's affecting this, availability. And also, people come to me asking how they're going to know whether they will have access to like the annual respiratory season vaccines, so like COVID, flu, and RSV. And so, could you maybe just explain what needs to line up for somebody to get access to those vaccines, and how people should answer this question for themselves, since it's so heterogeneous based on what state, even maybe what county you live in, and what insurance you have? Sorry, that's a lot of questions.
Okay, if you look at that New England Journal article that I mentioned, I think Helen Shu is the first author and Lynn Chen is the last author. There's a really nice illustration from your local epidemiologist that goes through the steps of vaccine policy. And the first step is that VRBPAC, VRBPAC, is a committee for FDA that's going to receive the materials about the vaccine, might be considering what kind of flu strains and so on to be thinking about. Then that committee will give a recommendation that FDA then does something with, typically says an agreement. At that point, once it's been licensed and it becomes legal to provide, then it moves on to ACIP, and ACIP looks at it and says whatever they say. And then now that we have a CDC director, again, the CDC director will approve the recommendation by ACIP, probably approve. The CDC director has occasionally overridden ACIP advice. So those are the steps that you go through. At least that's a good example for seasonal influenza vaccine, but it also applies to COVID-19 vaccines and then to the RSV antibodies and so on. Does that give you some of what you wanted?
Some. I mean, I think there's also the insurance companies.
Oh, okay. So,
The state needs to acquire supply.
yeah, so a couple things happen. One is that I mentioned before, the Affordable Care Act requires first dollar coverage for vaccines. And some research has shown that once the So research has shown that within. Oh, all right. Basically within like a week or a month, or very, very soon after ACIP does their vote, a third of insurance companies, private insurance companies, cover that vaccine. When it becomes published in MMWR, usually a few months later, another third cover it. And then by the end of a year, once a year cycle has gone through, all the insurance companies are pretty much online. For public insurance, that would be VFC, and that's just for kids through age 18. It's covered as of the publication, I think, is the publication in MMWR. But in terms of the access, there's a lot more to it, like the vote on thimerosal created all sorts of havoc because most organizations had already ordered all of their flu vaccine supplies, and so it just creates, there's a lot of lead time in all this stuff. It happens months half a year in advance.
I'm sure you guys have probably heard recently Health Secretary Kennedy canceled 22 grants into mRNA research and development, including one here at Emory University. I'm curious how you guys see that impacting the future of vaccine research, vaccine development for, I guess, diseases that we don't currently have vaccines for.
It's a huge deal. When you look at like the history of vaccine science in the U.S., we have evolved over time. Our vaccines have gotten better. The vaccines we give today are safer and more effective than the vaccines. Some of the vaccines we were giving 30, 40 years ago, some of them are the same, but for some vaccines, for example, like tetanus-containing vaccines, we have better vaccines today because we've had innovations in bioscience. So mRNA has really been an important frontier. I think as many people here know, like it has been under development, and COVID was just like the first time we really got it to work. So I think it's going to be huge in terms of like how we respond to future pandemics. I'll also say in the policy space, some of these bills that we're seeing in state legislatures are written so broadly that they include like gene-based therapies for like cancers. And so I think one of the policy concerns is out there is if there are these policy pushes to get rid of mRNA, what else or what other consequences are we going to see outside of vaccines? I think that's something to watch.
I think there's a few issues. One is that the public sort of knows what an mRNA is, but they don't really know. They just know it's kind of like a fancy vaccine or maybe a new vaccine. They remember maybe something at warp speed. It's the Trump vaccine. I mean, there's a lot of different ways to think about it, but the sowing of doubt is a big consequence. I'm particularly concerned about HIV vaccines. We've had no luck in developing any of them at all, and there's a good one for an mRNA vaccine for HIV. mRNA vaccines are hope. They give us hope for incurable diseases, for solving health problems that have no other solution. They sped up the solution for COVID-19 vaccines. That's good. But there are other diseases that require cures or ways of being addressed that mRNA technology can offer. So for me, mRNA, the brand is hope. And taking them away is taking away hope.
I want to add to that. A lot of people may not realize this, or you may realize this. The RSV vaccines that are recommended are mRNA vaccines. And in fact, the technology that led to the development of the RSV vaccines is also the same technology that allowed us to get the mRNA COVID vaccines. The same scientist was involved in those. And so we already have other vaccines out there besides COVID that have been approved and are being recommended that are mRNA.
Thanks, y'all, for your presentation. Sorry, I have one more thing.
One more.
Okay, so you mentioned that for measles, with every death, there's 1,000 cases, roughly, estimate. So we haven't had any deaths in Georgia, but we have had 6 positive reported cases by public health. So what is the level of transmission, if we're thinking about estimates, looks like for cases instead of deaths?
The reproductive value for measles is 18. According to one estimate, that for every case, 18 more people are infected. It's one of the most infectious diseases that we have. Now, when you look at the science, maybe it's 12. Whatever it is, it's astronomical. We all worry about HIV. HIV is a reproductive rate of 2. So these are very different things. Also, I'll just throw this in since we haven't talked about it. Measles erases your immune system. So when you get measles, whatever you had developed along the way, it's gone. So you walk into every infectious disease completely new. So you might get very sick from measles and have lasting problems like loss of hearing or sight or what have you, but then you're going to just go through another 5 years of heaven knows what.
On a hopeful note, which is to connect with what Noel said, is that measles spread can get worse in the U.S. It could be much worse right now if our vaccination rates weren't as high as they are, because like he said, this disease right now is spreading, but it's hitting people that are vaccinated. I think about this in Montana because we've had about over 30 cases. And of course, it's going to break through with unvaccinated people, but it's really vaccinated people in our population who are keeping it from being much worse.
Also, a note on the death rate. That death rate is only for acute cases. It does not include cases from SSPE, subacute sclerosing encephalitis, which is a long-term complication that can occur from measles, and it can develop 10 years later. It's very rare. It only occurs in about 18 out of 100,000 cases, but we don't have a lot of great data on it, and if you get it, it's terminal. You do not survive ever. No one has ever survived it. The longest survival has been something like 10 years. It's kind of like Alzheimer's for kids.
Oh, man. Well, on that note,
I was trying to end on a positive note.
I know, you tried. You tried, and Tara had to, like, bum us all out. Thank you very much for that excellent panel. And thanks to all of you who stayed in the room and hung in there with us. It's been a long day, but I hope that you found it as interesting as I did. Virtual audience, thank you for joining us. And I also really have to thank Corey Milburn, our videographer back there, who stuck it out today through thick and thin when we lost our connection a couple times. But yeah, really glad we were able to do this and that you were able to come. I want to thank the Georgia Health Initiative again, and the Robert Wood Johnson Foundation, and the Commonwealth Fund. So we'll see you at the next AHCJ event. Thank you for coming.